Asthmatic patients present with one or some of the following four symptoms. The first and the most common one is episodic shortness of breath, which is breathlessness which occurs for a shorter period of time and is non-progressive. It can occur spontaneously or following an exposure to a pollen grain, exercise, or exposure to cold air, and it will terminate spontaneously or following inhalation of a bronchodilator. Similar history in the past or during childhood is an important clue for diagnosing asthma. The second symptom is tightness of chest, and the third one is wheezing. These three symptoms, that is, tightness of chest, wheezing, and episodic shortness of breath, is caused due to episodic bronchoconstriction. Fourth symptom is cough with mucus production, which is non-purulent. Some patient may have cough alone as the symptom of asthma, which is called as cough variant asthma. On inspection, if we observe expiratory phase prolonged compared to an inspiratory phase, we can suspect a obstructive airway disease. Patient will be tachypneic on auscultation. If the asthma is severe, the chest will be silent. If the asthmatic attack is less severe, we can hear a polyphonic wheeze and the expiratory phase will be prolonged compared to the inspiratory phase. This is because during expiration, the thoracic cavity size reduces progressively and the obstruction becomes more severe. Whenever a patient presents with an asthmatic attack, based on the severity of the asthmatic attack, we can treat the patient with one among the following options. We can increase the frequency of beta-2 agonist inhalation. We can increase the dose of inhaled corticosteroids. We can nebulize the patient with inhaled corticosteroids and beta-2 agonist. We can give IV corticosteroids. We can ventilate the patient with NAV or mechanical ventilation. When a patient presents with an asthmatic attack of mild to moderate severity, initially we can treat the patient by increasing the frequency of inhaled beta-2 agonist for every 1 hourly and by increasing the dose of inhaled corticosteroids up to 4 times. If the patient remains symptomatic after 3 to 4 hours, we can nebulize the patient with beta-2 agonist for every 20 minutes. And if the patient still remains symptomatic after 1 to 2 hours, we can provide IV corticosteroids. If the patient is still tachypneic for 4 to 6 hours, we have to provide the patient with continuous beta-2 agonist inhalation and we have to ventilate the patient with non-invasive ventilation. If the patient is still symptomatic or if the patient is drowsy, ABG of the patient should be taken. In general, if a patient is tachypneic due to causes other than airway obstruction, CO2 will be washed out due to increase in the respiratory rate. In case of airway obstruction, CO2 will be retained and the partial pressure of carbon dioxide in ABG will be near normal or above normal, that is above 40 millimeters of mercury. In such situation, there is more chances of respiratory failure and patient has to be intubated and mechanical ventilation should be done. The optimal ventilator setting should be lower respiratory rate of 9 to 12 breaths per minute, average tidal volume of 7 to 9 ml per kg. These settings leads to minute volume of 10 liters per minute.